Well, sorry about that. So last week we had Logan presenting history and examination, just an overview. And then these are a few of the upcoming sessions we'll be having. So the link that I had earlier on, which Natalie will also put into the chat, will take you to, it's an Eventbrite link. It will take you to sign up for all the future talks. Okay, so as I was saying, we aren't going to go through the basics. You can learn that by reading a textbook and online, watching some online videos. And we'll be going through approaches to stations, how to present your findings, how to come up with differential diagnoses, and then just discussing the next steps involving investigations and management. So I think I was on this slide before, but you guys couldn't see it. But I think the most important thing is that you should all practice on as many people as you can, friends, family, to find out what normal is like. And then also just helps you refine your technique and find a systematic approach that works for you. You don't have to follow a specific approach. Just find something that you can follow and is logical for you, and something that's easy for you to remember. And then also be brave and offer to present on ward rounds, present to colleagues and friends. It just helps. Okay, so we'll start with today's talk is just only on cardio and respiratory examinations, just in terms of some general principles. So we'll start with WIPER QQ. So WIPER stands for wash hands, introduce yourself, ask for permission to examine the patient, and then expose the patient and only expose the relevant areas, and then reposition depending on which examination you're doing. And then QQ stands for the two questions you should be asking. So number one is, are you comfortable? And the second question is, are you in any pain? So that's how you should start all your stations. And then in terms of the IIPPA, that stands for basically what you'll do at all clinical examinations. So you firstly start with inspection, and then palpation, percussion, and then finally auscultation. And then you move on to investigations. So firstly, bedside investigations, bloods, imaging, and then other investigations. So to make sure that you really refine your technique, make sure you always have a stepwise approach, present logically, and try and calm yourself down before presenting your findings. And then also come up with differentials. You can come up with the most likely differentials, and then as well as the most life-threatening ones as well. And then also identify causes and complications so that it basically shows the examiner that you know how to manage them and identify them. So we'll start with the cardiac examination. So we've been through the WIPER QQ and then the IIPPA, and then need to go systematically. So I normally start with looking at the hands, then arms, and working my way up towards the face and neck. And then I move on to the chest. And I always start with inspection. It's important to look around the bedside as well. So just before you start, spend a few seconds looking at what's around the patient, and also just looking at the patient themselves. So does the patient appear well, or do they look unwell? This is something you'll gauge with time and with practice. And then do they look cyanosed? So do they look a little bit blue? You can see central cyanosis by looking at their lips, and then peripheral cyanosis by looking at their nails, but we'll come on to that just now. Or do they look flushed? Do they look a bit red or pink in their face? And then after this, so this is basically part of the edge of the bed assessment. So like I said before, look briefly at the surroundings while introducing yourself. Just look at everything around the bedside. And then make sure you also look at if there's a vitals monitor, like this shown. Let me try look the laser or arrow. I don't know if this is good. Oh, no, that just changed the slide. It's fine. Oh, laser pointer. Okay, can you see that? The laser pointer.
Yep, we can see it.
Okay, great. So, so if there is a bedside monitor, you want to look at the blood pressure. So this one is systolic blood pressure, and this is the diastolic blood pressure. You look at the pulse, and then look at the oxygen saturation level, and then finally the respiratory rate. So it gives you pretty useful information on this monitor, and then it will save you time from actually calculating it, like actually having to count the respiratory rate or the pulse, and then the blood pressure is just there for you. But I think it's also important to show the examiner that you are able to demonstrate these skills. Yeah. Oh, sorry, just a few more important things on edge of the bed assessment. Look for things around the bed, like a glyceryl trinitrate spray, or like sputum pots, or fluid restriction signs, or reduced salt intake signs. These are all things that will be around the bedside, which will give you a clue as to what the patient has. So in terms of hands, can anyone tell me what they see? You can choose any of the images. What signs they see.
The first one is splinter hemorrhage.
Yeah, good.
The second one is clubbing. And
Yes.
the third one is they have written doseless node and
Yeah.
lesions. And the fifth one is palmar rhythm, I think.
Good.
And the other one is I'm not sure.
So it's xanthelasma, basically. So lipid deposition in the hands. So yes, as she said, the first picture is splinter hemorrhages. So these are the splinter hemorrhages. And then we have clubbing here. I have a specific slide on clubbing, but generally you should also be palpating, not just looking at clubbing. And then this is Osler's node, which is indicative of infective endocarditis. It is a tender nodule. And then this is Janeway lesion, which is also indicative of infective endocarditis. It's generally non-tender, so that's how you can differentiate. And it's a hemorrhagic macule or papule, which means you can sometimes palpate it. That's a papule, and a macule is sometimes just soft and you can't palpate it. And it's generally found on the palms or on the soles of the feet. And this is showing palmar erythema. It wouldn't really be, it might not be present in the cardiovascular examination if they're giving you a cardiac patient, but it's just something to think about in the context of alcoholic liver disease, which can worsen heart failure or be a cause of heart failure. And then this is the xanthelasmatosis, which of the hands. So just lipid deposition in the hands. Okay, so moving on to the pulses. So I start at the hands and then I move up to the radial pulse. And then while you're looking at the hands, I also just feel, while I'm feeling the radial pulse, I'll assess the temperature. So do the peripheries feel cold or not? And can anyone tell me what this could indicate if the peripheries are cold in terms of a cardiac examination?
Hypoperfusion.
Good.
Someone's written signs of shock as well.
Yeah, good. So both of those. Hypoperfusion, which is basically a feature which can indicate shock. And then also so this could be evident in congestive cardiac failure, for example. And then moving on to feeling the radial pulse. So when you're feeling the radial pulse, you need to assess two things, the rate and the rhythm or regularity. In terms of the rate, a normal pulse is between 60 and 100 beats per minute, and tachycardia is anything over 100 beats per minute, with bradycardia being less than 60 beats per minute. In terms of regularity, you just need to see whether each beat is happening symmetrically, basically. So can you hear that? Versus So you just need to basically feel and time whether the beats are happening at an equal time from one beat to the other. And then whether it's just haphazard beating, which could indicate atrial fibrillation. And then finally, you move up to the brachial pulse. And then at the brachial pulse, you want to assess the character and volume. So is it a very bounding pulse? And then you also, while you're around that region, you assess whether the pulse is collapsing or not. So this is indicated in the figure. So generally you should let the patient know that, you want them to relax and you'll be moving their arm. So you don't want them to be contracting their muscles or stiffening them. And then, so you ask them to lie back and relax with one hand on the radial pulse as indicated here, and the other hand on the muscular area of the forearm, so just before the antecubital fossa. You'll hold those two areas. So this hand is palpating the radial pulse and this one is on the muscular region, not applying too much pressure, but just positioning your hand over the muscular area. And then while holding these two areas, you'll rapidly raise the arm. So as you see, he's lifting until he lifts it up there. You can even lift it a bit further. And if you do have a collapsing pulse, or also known as a water hammer pulse, you'll feel a tapping impulse, which will be transmitted from here. Can you all see the laser pointer?
Yes.
Okay. Which will be transmitted from here and it will run down and you will feel it hitting against your second hand. And this can be indicative of aortic regurgitation, collapsing or water hammer pulse. So in terms of arms, can anyone tell me what they see? Don't worry about the blood pressure cuff, but in these first two images.
Is the first one cholesterol deposition?
Yes, the first one is xanthoma on the elbow, and then the second one.
Is it needle track marks?
Yeah, needle track marks. So if you're suspecting infective endocarditis and an IV drug user, then you'll see the needle track marks. And then I have the blood pressure here because it's always important to ask for the blood pressure. And also while you're doing that, ask for the temperature, you can count the respiratory rate. But the blood pressure is quite an important thing because it can also show you if there's a wide or narrow pulse pressure. So which can indicate certain valvular heart lesions, which we'll go over a bit later. And then moving on to the face, can anyone tell me what they see?
First one is xanthoma. The second one down, the second down one is something like K-fring.
Sorry?
Or a arcus. It can be K-fring or a arcus analis.
Yes, arcus.
I'm not sure about the age of the patient. And
this one?
That's geographic tongue.
No, it's not geographical tongue. It's glossitis.
Oh, okay.
That's fine. Don't worry about it.
A few people have also put in the chat jaundice, xanthelasma, corneal arcus, and pale sclera query anemia.
Good. And this one is showing dental caries. And this one is angular stomatitis, if you just see here, the edges. And then, so this is xanthelasma when it's on the eyes. And then when it's on, peripheral, like on the hands or feet, it's xanthoma, or especially, actually, that's more when it's near tendons. So pallor, why it's important is because if you have someone you inspect, if you have a patient and you're suspecting cardiac failure, then it could be precipitated by anemia. And then like she said, corneal arcus is mostly found in elderly patients. And then another important sign, which we don't really have a picture of, but you can all Google it, is something called head bobbing. And it can be evident in patients with aortic regurgitation, where you actually see a visible pulsation they might be sitting still, but you actually see the head lifting slightly. Might be a good idea to just have a look at that on YouTube.
What was the tooth one with the decay? Is
Dental caries. So
okay?
infective endocarditis, if you're looking for a source, you should always just check the mouth.
Okay, thank you.
Sorry. So now we're moving on to the neck and chest. Can anyone name these scars? So if this was on your patient's chest. So these scars. If you can't, it's all right. Okay.
Thoracotomy is right, lateral thoracotomy scar, and the other one is median sternotomy scar.
This one, median sternotomy.
Yes, I think so.
And this one?
I'm not sure.
Okay, this is a pacemaker scar, number 2. Number 1 is a median sternotomy scar. Number 3 is a posterior lateral thoracotomy scar. So this emphasizes the importance of always looking at the front and the back of the chest. Number 4 is an anterior lateral thoracotomy scar. And 5 is axillary. So these are the different thoracotomy scars. The midline one is a sternotomy because the sternum is just here. And then this, just think of the heart pacemaker. Can also be a valve replacement, but generally it's a much smaller scar nowadays. And then also while you're looking at the chest, count the respiratory rate. And just remember that a normal respiratory rate is between 12 and 16. And then this is just to show the JVP. We'll go into detail about that just now. Okay, so next we move on to looking at the chest. So do you actually see the precordium moving? So the precordium is just a fancy word for the area, including the heart, like the heart area. So do you actually see a visible pulsation? And then next you move on to feeling the chest. So generally, I like to first put my hand vertically on the chest here to feel in for any heaves, thrills. And then I move, so I put it vertically here and then as in the diagram, and then over each of the valves to feel for any palpable murmurs, which are thrills. And then finally, the apex beat, which is usually found in the 5th intercostal space mid-clavicular line. So for the apex beat, you need to describe the location. So in terms of which intercostal space you feel it in, and where about in terms of the mid-clavicular line. So if you look at the clavicle here, this is the mid-clavicular line. And then the mid-axillary line, well, sorry, that's the, yeah, and then the mid-axillary line is somewhere here. So you need to describe the apex beat, whether it's displaced laterally to the mid-clavicular line or even further laterally, so lateral of the anterior axillary line. But we'll also go over that now. So in terms of the intercostal spaces, I think this is very important because I've seen quite a lot of people asking about how you actually know where the different valves are and where the intercostal spaces are. So if you all feel on yourselves now, you have the clavicle coming in to the manubrium. And if you feel along your neck and go down to where there's a little gap, if you can all do that now, coming off the manubrium will be the first rib. And then that will obviously be the first intercostal space and then the second intercostal space. So if you think about that, when you're assessing your patient, this is how easy it can be for you to find the second intercostal space for, you know, the aortic valve, for instance. And then the angle of Louis, which is round about here, it correlates with the T4 to T5 intervertebral disc. And it also divides the mediastinum into superior and inferior mediastinum. Okay, so moving back to the apex beat, well, looking at it in more detail. So you need to make sure you're feeling just below the nipple in the fifth intercostal space. And then you should first palpate with the palm of your hand to feel where the pulsation is. You can feel it maximal intensity. And then once you've localized its location, you can take the tips of your fingers and then try and pinpoint where you're feeling that apex beat the best. A tip for trying to accentuate the apex beat is you ask the patient to turn over onto their left lateral if they can, and then you'll be able to pinpoint its location better. And then just in terms of the use of the apex beat, well, it correlates with the left ventricular contraction. And so it basically provides an indication of the left ventricular function. And then always remember that sometimes an apex beat is not palpable. So don't spend too many minutes wasting time trying to locate the apex beat when it might not be there for a variety of reasons, such as a really thick chest wall, obesity, emphysema, pericardial effusion, or dextrocardia. So just keep that in mind. If you don't feel it, move on. And then, so this is just showing localization with a single finger and then turning over onto the left lateral position. Okay, so moving on to the JVP now. Because we have quite a mixed audience, I'm not going to go into too much detail about the JVP, but we'll just look at the several different waves in the JVP, but in terms of clinical examination, you don't need to worry about that. But a nice mnemonic that I've always used is, so if you're looking at this, the A wave indicates atrial contraction, C is tricuspid closure, X is atrial relaxation, V is preparation for ventricular contraction, and then Y is the atrial emptying. In terms of how you actually measure the JVP, so you need to position the patient in a semi-recumbent position, which basically means at a 45-degree angle, as indicated here. And then ask the patient to turn their head slightly towards the left and make sure you have good lighting in the room you're using. And then you'll be looking for evidence of the internal jugular vein running between the medial end of the clavicle and the earlobe. And then under the medial aspect of the sternocleidomastoid, you'll see a double wave pulsation. And that's how you'll know that it's the internal jugular vein. And then you'll need to measure the jugular venous pressure. So to measure the JVP, so say, for example, we see it somewhere here, you would take well, I've never really seen people taking a ruler. It's more like you just estimate, or yeah, I normally just estimate. And so you're measuring from the sternal angle, the vertical distance between the sternal angle and the top of the pulsation where you see the internal jugular vein. How you can make sure it is the JVP and not the carotid pulsation, which is a common problem, is that the internal jugular vein, the pulsation from there is not palpable. You shouldn't be able to feel it. Whereas the carotid pulse, you'll actually feel the bounding of the pulse. The JVP can be readily occluded. So if you put pressure on it, it will stop. But the carotid pulse, you cannot occlude it. In terms of location, it's generally between the heads of the sternocleidomastoid, lateral to the carotid. The JVP drops with inspiration, and it's generally biphasic. So you see it has a double impulse. And then it also drops when sitting erect. So going on to murmurs, I think most people struggle with murmurs just because it takes a lot of time and you have to you have to ignore background noise, etc. So in terms of auscultation, I always start with listening to the carotids, because you never know when a patient's going to have a carotid bruit, indicating carotid artery stenosis. And then in terms of listening over the actual valves, so the aortic valve is located in the second intercostal space. It's actually, the valve is not located there. It's just where you will hear aortic pathology the best would be in the second intercostal space, to the right of the sternal border. And then the pulmonary valve, you will hear over the second intercostal space, but to the left of the sternal border. And then the tricuspid valve will be in the fifth intercostal space, to the lower left sternal border. And then the mitral valve will be in a similar position to the apex beat. So fifth intercostal space, midclavicular line. And that's the midclavicular line again. Okay, and then for murmurs, you need to pinpoint the position where it is the loudest and describe that or feed that back to the examiner. And also you need to be able to say whether it's systolic or diastolic. Can anyone tell me how we can differentiate between the two? Anyone? Okay, so basically a systolic murmur, when you're listening to any murmurs, you should be timing with the carotid pulse or the radial pulse. Actually, you shouldn't use the radial pulse, you use the brachial or the carotid pulse. And by timing the pulse, it will tell you whether it's systolic or diastolic. If the murmur coincides with the pulse, it's a systolic murmur. If it doesn't, if it comes after, then it's a diastolic murmur. And then as you get more practice, you'll be able to tell whether it's an early, mid, late, or pansystolic murmur, or another type of murmur. And then we'll go over grading on the next slide. And then also think about whether there are any added heart sounds. Just a bit of background in terms of the heart sound. So you have the first heart sound, or S1, which is generally the lub. It's a dull, low-pitched sound. It signifies closure of the atrioventricular valves, so the tricuspid and mitral valves. And it's generally longer than the second heart sound. And it's in time with the carotid pulsation. In terms of the second heart sound, or S2, it sounds like a dub, and it's a bit higher pitched, it's shorter, and it signifies closure of the semilunar valves, so closure of the aortic and pulmonary valves. Sometimes you get added heart sounds. So for example, in S3, and this is generally an added sound at the start of diastole, so after S2. And you can sometimes accentuate this by turning the patient onto the left lateral. And generally an S3 can be present in congestive cardiac failure. And then you can also get an S4 or a gallop rhythm. And generally the S4 is heard before the first heart sound. And it can also be accentuated by turning the patient onto the left lateral. Generally, this can be found in elderly patients, or if someone has had an MI or myocardial infarction, for those who aren't aware of that. So another tip for murmurs, a way to remember which murmurs increase on inspiration or expiration, is a little mnemonic that I've been using since medical school, except the last word has been changed. All people try masks. So if you imagine the aortic and mitral valves, maybe I can go back to this picture. Aortic and mitral valves, they're basically on the outside, if you can kind of imagine that. So they are louder on expiration because they're the outer valves. And then the pulmonary and tricuspid valves, they're closer together, and on the inside, they're closer to each other. So they are accentuated or louder on inspiration.
I just wanted to point out, because someone mentioned in the chat, that in some places you do see that the tricuspid is in the fourth intercostal space just because of the way the ribs curve as they come out.
Yeah.
So I just wanted to mention some places it does say fourth intercostal space.
Yeah, that's fine. Thanks for that. Okay, so we've done that. In terms of grading of murmurs, this is also something quite important. It also just refines your technique and how you present back to the examiner and shows that you know what you're doing. A grade 1 murmur, generally only a cardiologist should be able to hear that. So heard by an expert in optimum conditions. Grade 2 can be heard by a non-expert, but also in optimum conditions, so no background noise. Grade 3 is easily heard, but without a thrill, so no palpable murmur. Grade 4 is a loud murmur with the palpable thrill, so you hear the murmur really well, and you can also feel the murmur. Grade 5, the murmur is really loud, and then it's often heard over a wide area, so not just over the specific location. And then there's also palpable thrill. And then grade 6 is extremely loud, and you can hear it without a stethoscope. I think I've only ever heard a grade 6 once or twice. And then, so in terms of grading, when you're presenting back, you could say, for example, this patient has pansystolic murmur, grade 3 out of 6. I think it just indicates that, you know, you put some thought into it and you know about murmurs, about the grading. So just a summary of when thinking about murmurs, think about firstly the location, whether it's loud on inspiration or expiration, where it radiates to, the grading, so the number out of 6 you think it fits best with. And then also at the back of your mind, just keep at the back of your mind thinking about what does this all mean? So it's little pieces of the puzzle that's going to put together a diagnosis at the end. Okay, so this is mostly for your reading. It's just, it might be a bit scary to some of you. But we tried to summarize on a page basically all the different murmurs. So we have here aortic stenosis. So it's an ejection systolic murmur. I'm just going to explain this one so that you all know how this works. So aortic stenosis, it's a systolic murmur, it's ejection systolic. Causes could be calcification, congenital, rheumatic fever, infective endocarditis. Symptoms are generally the classic triad of angina, so chest pain, shortness of breath, and syncope. Three classic features. There could also be symptoms of left ventricular failure, such as PND, which is paroxysmal nocturnal dyspnea, orthopnea, frothy sputum. So frothy sputum is literally, it looks frothy and it can be a bit pink, very lightly pink, and sudden death. And then the signs, forceful apex beat, aortic thrill, and then this, the murmur itself radiates up towards the carotids, and that's how you can tell the difference between aortic stenosis and aortic sclerosis. So aortic stenosis is pathological. Aortic sclerosis happens with age, and how you can differentiate between the two is aortic sclerosis will be localized to the second intercostal space. It doesn't radiate anywhere else. It generally is unchanged with inspiration or expiration. So this is basically, you can have a look at each of these little boxes for the different ones. So aortic regurg, early diastolic, mitral stenosis, late or mid diastolic, mitral regurg, pansystolic, and then I think it's if you want to take a screenshot or picture, it'd be a good idea. So it's the same thing continued with the other murmurs, but less common except for tricuspid regurg, but these three are less common. So you might not be faced with them, but same principle. And then just a note about always looking at the back. So always look at the back of the chest for scars. And then don't forget to palpate for sacral edema. And remember though that this nail mark, you shouldn't really be seeing that. You should be applying pressure, but not a significant amount of pressure to cause discomfort. Okay, and then also just don't forget to look at the lower limbs. So here we can see saphenous vein harvesting, so scar from this. And this would basically be used in a coronary artery bypass graft. So it could give you valuable information that this patient has had a myocardial infarct before that actually required a cabbage. And then this is just showing checking for peripheral or ankle edema. So you should press for 5 seconds. Don't press too hard because it can be quite painful when patients have edema. And then you see an indentation which will last a few seconds, indicating edema. So then just putting everything together. So thinking about other things you should be examining. So in terms of peripheral pulses, if you're suspecting aortic regurgitation, you can examine the femorals if the patient is happy for you to do so. So what you'll be doing at the femorals is you can listen for pistol shot femorals. Again, this might be a bit too complicated for this talk, but you can always, if you have an interest in this, you can search a video on YouTube. But basically, it's all about occluding the femoral and listening distally or proximally to hear if there's a murmur. And then, actually, that's Durazier's sign. Pistol shot femorals are just when you do hear a murmur. And then other examinations, so feeling the abdomen for a triple A, so feeling if there's a significant pulsation in the abdomen, and then listening to the lung bases, because in congestive cardiac failure, you get bibasal crackles due to pulmonary edema. And then finally, I already mentioned sacral and ankle edema, press for 5 seconds and don't put too much pressure. And then putting it all together, you need to also be thinking about what bloods you want and what your main differential is. And then an ECG, chest X-ray, echocardiogram, but really it depends on the case you get. And then finally, angiography. Also angiography depending on whether you're getting a patient with an MI or not. So how I like to summarize my findings, this is what I basically did in medical school. You don't need to follow this at all. You can do whatever, however you like to put things together. But basically, I would say I performed a cardiovascular examination in Mr. X, who is a 55-year-old with signs suggestive of congestive cardiac failure, which was evidenced by his pulsus alternans. Sorry, I know we didn't talk about that, but that's something you find in CCF. The pulse can have basically different varying pressures when you feel, so varying intensity of the pulse as you feel the pulse. And then a raised JVP, bibasal crackles, putting ankle edema until the mid-calf, and tender hepatomegaly. Sorry, I don't think I mentioned that on the previous slide, but something you should also examine is always examine the liver if you think that this patient has CCF. And then the next part, you'd say something like my differential diagnoses include, and just mention one or two. And then before the examiner asks you what investigations you'd like to perform, it's nice to always just anticipate this and say, I would like to perform an ECG, but always say why you're doing something. So I'd like to perform an ECG to look for any previous or current MIs, bloods, including a full blood count to look for anemia, which could be a precipitant for CCF, urea and electrolytes to assess renal function, potassium and sodium levels, liver function due to the presence of tender hepatomegaly in this patient, BNP to assess the severity of the CCF, and then a TFT, so thyroid function test, to ensure that hypo or hypothyroidism is not a precipitant. And then I'd also like to perform a chest X-ray to assess the severity of the pulmonary edema, and arrange an echo to assess the systolic function of the heart and look for any valvular dysfunction. And then finally, you'll just end off with your management, even before the examiner asks, and I'm sure you'll do really well. So this is just an example of putting everything together. So for example, if you had a patient with aortic stenosis, you should also know a bit about the condition, so know the top causes, the signs, complications, what you should expect to see on investigations, and the management plan. Okay, so we're gonna go through a few cases before we have a little break before we start respiratory. So can anyone tell me what they think this is? So it's a patient born in 1942, presenting with these 4 pictures. You can also put it in the chat if you want.
Someone's written undergone cabbage, aortic stenosis, atherosclerosis.
Yeah.
What is the hand sign someone's written?
Okay, so we had that one earlier. So it's the xanthoma, cholesterol deposits on the hand. That's the hand sign. This is a median stenotomy scar. So they've obviously had a cabbage. And then the vein harvesting here, and this is arcus senilis. So arcus senilis can happen in elderly patients, but also in patients with high cholesterol. Okay, the next case, go to the next. Okay, so what would be your diagnosis here? So patient born in 1982 with these hand signs and the same scar.
Someone's written infective endocarditis, which is really good, but what about the scar?
Yeah.
What might they have needed to have done?
Okay, not a cabbage, but when you have infective endocarditis, yeah, valve replacement.
Really
Good. Yep, that's it. And then, so just to summarize everything, so remember your wiper QQ before you start the double I, double PA. Remember other related systems, so listening to the bases of the lungs, feeling for hepatomegaly, remember your investigations, and then just a brief management plan.
Just for the YouTube viewers, I don't know if you wanted to go over what the diagnoses were for both the photos.
Okay, let me go back. So the diagnosis here was infective endocarditis because of the splinter hemorrhages. And what would you guys say is this? What sign is this? We had the same picture earlier.
OSCEs nodes.
Yes, good. Okay. So what's the difference between Janeway and Osler's nodes?
OSCEs are tender nodules at the tip. Janeway is just like macular rashes in the palm, which are not painful.
Yes, and not palpable. Sometimes not palpable, they can be a papule. And then this is a median sternotomy scar, just to go over for everyone. And then going back to this slide, so median sternotomy scar, arcus senilis, xanthoma of the hand, and saphenous vein harvesting.
So the first guy had a cabbage, even though he's got the same scar, he had a different operation because he's got.
This guy had a cabbage, but the second patient had a mitral valve replacement, or one of the valves. But commonly, the most commonly affected in infective endocarditis would be the mitral or tricuspid valves. Okay, so we're gonna have a little break for 5 minutes before the respiratory section. So you can ask questions in the chat, just take 5 minutes, go have something to drink or something to eat. Is that okay with everyone? What's the first diagnosis again? Okay. So this is myocardial infarction with, so previous MI with atherosclerosis. So features of dyslipidemia and evidence of having a cabbage. Yeah, so full heart transplant, generally nowadays for valve replacements, we don't have such big scars. So it will be a much smaller scar. Sorry, what do you mean? Okay, so we'll come back at 7 and start respiratory.
What bit do you want us to spell? Sorry. Oh, yeah. It sounds like cabbage, but it's CABG.
Yeah.
Yeah, it is dinner time, to be fair.
Okay, so we'll be back at 7. Sorry, so someone just asked, what does IIPPA stand for again? So it stands for inspect, palpate, percuss, auscultate. And then the wiper QQ is wash hands, introduce yourself, ask for permission to examine the patient, expose the area you're going to examine, reposition the patient. So for cardiac examination, you put them at a 45-degree angle, and then ask them if QQ is just the 2 questions you ask. So firstly, are you comfortable? And then the second question is, are you in any pain? And then you could also just always say, if at any point you feel uncomfortable, please let me know and we can stop. No problem. So we have 1 more minute, then we'll start respiratory. Someone iPad just asked, when in an OSCE, do you say out loud, what you can and can't see in medical terms. No, you say them in medical terms if you know the name. If you can't remember the name, you could say lipid deposition in the hands or something like that. But if you know the name, just use the name. Some examiners, you can ask them at the beginning of the OSCE if they like you to talk through what you're doing. Some really like that. Others will just say, just present at the end, and they don't care. They don't care about you verbalizing what you're doing as you go along. But generally, I like to verbalize what I'm doing. So I'm now feeling for the radial pulse, and the rate is 60, it's regular, you know, that's, but it also just depends on the examiner. Okay, so I think we'll start respiratory now. So same thing, we're not going to be going over things that are like the basics, but we'll be going over most aspects. So just to refresh and revise, so wiper QQ. So this is what you already know, wiper QQ and the double I, double PA. So to remind everyone, wiper stands for wash your hands, introduce yourself, and also importantly, get the patient's identity. So confirm that, are you Mrs. So-and-so? Then ask for permission to examine them. And you can also here offer a chaperone. And then E stands for expose the patient. And then R is reposition. So for respiratory examination, they should be sitting up at about 45 degrees. And then QQ are the two questions you should be asking your patient. So are you in any pain and are you comfortable? And then just be systematic in how you examine them. So go from, it's really up to you, but I like to go from, I start at the edge of the bed actually, then go to the hands and the pulse and move up to the forearm, then neck and head. And then I work my way down. So chest and then finally lower limbs. So edge of the bed assessment. So while you're introducing yourself, look at your surroundings. There are a lot of important clues around there. And then can anyone tell me what they see in this picture? So they need to name everything they see. You can also put it in the chat.
Someone's put pursing lips, cachectic, oxygen, frail, really good stuff. Tripod.
Good. Yeah. So this would be likely in someone with COPD. So they've got pursed lips, they're in a tripod position, they have cachexia. So for everyone for people who don't know, cachexia is extreme muscle wasting. So you can see there's a lot of loss of muscle and a lot of wasting. And then, well, you can't actually see it, but there could also be accessory muscle use or signs of respiratory distress. So alar flaring, increased work of breathing, increased respiratory rate. Can anyone name this? So things to look out for at the bedside. Can anyone name this device?
Someone's put Venturi.
Yeah, good. Venturi, very good. And the next one, can anyone name this? Non-rebreather mask, good. And this one? So it's a mini right spirometer, but basically peak flow. It does peak flow meter. And this? The last one? So it's nasal cannula. It doesn't only have to be for home oxygen. It's also for in hospital. So I'll just briefly talk through each of them. So the first is the Venturi mask. So why you'd use these different masks is because they're able to supply you with a different percentage of oxygen. So Venturi valve mask or mask valve delivers oxygen at a fixed concentration, depending on the color and size. Okay, so for example, The dark blue one generally, actually also this one could be, it generally tells you on the bottom, on the side of it, it tells you the percentage of oxygen it supplies. Generally the blue one supplies 24%, a concentration of 24% oxygen, and you generally have to put it on at 2 liters per minute. So the oxygen needs to be flowing at 2 liters per minute. The white one, I'm just going to name a few of them to give you an idea. The white one generally supplies an oxygen concentration of 28%, and you have to put the oxygen on at 4 liters per minute. And then, for example, the green one, which isn't in this picture, but I think that's the highest amount for a Venturi mask, which is 60%, and you have to have that at 15 liters per minute. So basically how a Venturi mask works is that air flows through and it entrains the air to deliver that specific concentration of oxygen. So it's important that you keep the oxygen open to the right setting. So if it says 2 liters per minute, you should be following that. And then the next one, the non-rebreather mask. So if your patient is requiring more oxygen than with the Venturi, you use the non-rebreather. It can supply 60 to 80% concentration of oxygen. And this depends on how high you turn the oxygen up. So you can have it between 10 to 15 liters. You can have the oxygen as high as that. And then your mini right spirometer or peak expiratory flow meter. And then finally, nasal cannula. So this is only meant to supply a really low flow of oxygen. If you increase it too much, you'll hear that the tubing pops off the oxygen valve. So you can only use this at about 4 to 5 liters per minute, and it can only provide you with 28 to about 44% of oxygen concentration. Okay, so we're moving on to hands again. Can anyone tell me what they see? So we'll start with this one. Clubbing, but do you see anything else? So someone has said clubbing. Clubbing and bluish, yeah, that's correct. So there's clubbing here and cyanosis, and you can see these nails look normal and they're quite pink. Anyone tell me what this could be alluding to? Yep, CO2 flap, also known as a flapping tremor or asterixis, or some people call it wrist cocking. So how you do it is you ask the patient to extend their arms and cock their wrists to 90 degrees as indicated, and then observe their hands in this position for 30 seconds. A coarse flap could indicate carbon dioxide retention. So moving on to this picture. I can't really see the picture because my chat's in the way.
Thinner muscles wasting.
Yeah, so muscle wasting on the palms, very good. And then this picture. Yeah, nicotine staining, so tar or nicotine staining, indicating that this patient is a smoker. Just moving back to the thenar muscle, the muscle wasting, it could indicate a tumor at T1, because that's where the muscle wasting will occur. And then this is just showing palpation of the pulse. So don't forget that in the respiratory examination, you also need to feel the pulse. And can anyone tell me what this last picture is indicating? If a patient is an ex-smoker, they generally wouldn't have tar staining if they last smoked more than a month previously. If it's a week or 2 weeks, they might have tar staining. So this is not nail pitting. Nail pitting is more, you actually just see little dots in the nails, which are kind of transparent. It's a bit of a tough one. I just added it in there. Yeah, so there is some onycholysis, which is separation of the nail from the nail bed, but this is actually yellow nail. Well, it could be indicating yellow nail syndrome. So you can see yellow nails, you see onycholysis. There can sometimes be transverse ridging on the nails, loss of the cuticle and slow growth. And then there could be other features like lymphedema and pleural effusions to actually call it yellow nail syndrome, because to call it yellow nail syndrome, you need a triad of yellow nails, lymphedema, and pleural effusion. So lymphedema you could see in the lower limbs. So it's just blockage of the lymphatic system. And then clinically you would find a pleural effusion. But yeah, that's onycholysis. It could also correctly, as someone has said, and Becky has said in the chat, and AS, it could also just indicate a fungal infection of the nails. So good. So just to recap, when looking at the hands, again, as we mentioned in the cardio examination, feel the temperature. Warm pink peripheries could also be a sign of carbon dioxide retention. Look for clubbing, nicotine staining. If the patient has a tremor, it could also be indicative of recent salbutamol use. So beta-2 agonists can, the side effect of them is that they can cause a tremor. If there's a coarse flapping tremor, it could be carbon dioxide retention. And then again, just feel for the radial pulse, rate and rhythm. Calculate the respiratory rate. So normal is about 12 to 16. And then, yes, tremor, also alcoholism, but we're focusing on respiratory examination here. And then, so we'll move on to the next slide. So just a specific note on clubbing. The different stages of clubbing. So firstly, you can get the normal appearance of the nail, but there's actual fluctuancy at the base of the nail bed. So around here, it's something that you need to be feeling for instead of just looking. You feel sponginess at the base of the nail bed, and this is the earliest feature of fingernail clubbing. The next stage is when you get loss of the angle between the nail and the nail bed. So you see there's a little angle there. Here, it's straight. So that's stage 2. The next stage is increased curvature of the nail. Do you see how it's now curving instead of just straight? And then the last is when there's expansion of the terminal phalanx and a drum sticking appearance. So the protrusion here. So how you feel for clubbing? Well, how I assess for clubbing is we call it rocking the nail bed to feel for spongy tissue. And then also just looking at the nail and also asking the patient to put their 2 nails together like this, because this can show you whether Shamrot's window, which is this tiny space here, whether you're able to see Shamrot's window. So here, there is no clubbing, it's normal, because you're able to see Shamrot's window. But here, there is clubbing because this window has been completely obliterated. Okay, now, so moving on to the face, can anyone tell me what they see? Left eye droop. Someone said left eye droop, okay. Ptosis of which eye? Horner syndrome, good, left, yes. Okay, so this one is showing Horner syndrome. Anyone tell me what this is showing? There's the second one, the nose. Yes, this one is a tracheostomy, just for those of you who've never seen one before. Just wanted to add that in. This is actually a bit tricky. This is a cutaneous manifestation of sarcoidosis, which is called lupus pernio. That's here. Anyone tell me what this is showing? The lips? Yeah, central cyanosis. And then this is just showing wasting. And then it's also just a reminder of how you can feel when we go on to feel, I just want to use this image quickly to describe how you feel whether or not the trachea is central. So you'd be feeling here, and then between at the sternal notch, you'll be putting a finger in there, but be very gentle because it can be painful. And also always remember to have your nails very short for any clinical examination. And then here, you'd put your finger in there and feel to the left or right of the sternocleidomastoid to feel whether there's equal space between each of the sternocleidomastoids to see if the trachea is central. Also, sorry, this image is also showing that there's an enlarged lymph node here. So here, do you all see that? You can just say yes in the chat or no. So that's actually a Virchow's node. Okay, and then I've just put this image in just to remind you that for the cardiac, oh, how do you spell the node? It's VIRCHOW''S. Okay, and then the picture with the lymph nodes is just to remind you that you need to always examine the lymph nodes. We didn't really mention it in cardiovascular examination, but for all examinations, you need to do a little general exam. So feel for the lymph nodes. So you have the anterior cervical chain, posterior cervical chain, posterior auricular, so behind the ear, occipital, and then preauricular, parotid, retropharyngeal, submandibular, submental, anterior cervical, and then supraclavicular nodes. So just for this node, the Virchow's node, generally it can indicate gastrointestinal cancer because it actually drains to the abdomen and specifically the stomach. So it can indicate gastric cancer. This picture is just showing some purulent sputum. Sorry about that. So sorry for adding the sputum picture. But if someone is having an infective exacerbation of COPD or having pneumonia and you see this type of sputum, you will suspect it's bacterial. Just looking at the chest now, you need to look at the shape of the chest. So you can have a normal shaped chest or pectus carinatum. So there's a protrusion here. A barrel chest, so just symmetrical enlargement. Pectus excavatum, so like you're excavating, there's actually like a dip in the chest wall. Kyphosis, where the back is a bit protuberant, and then scoliosis, where it's asymmetrical. And then in terms of the chest, again, we just inspect. So look for deformities, look for features of superior vena caval syndrome or superior vena caval obstruction. So that's kind of indicated here. So when the superior vena cava is completely or partially blocked, you can get facial swelling, distended neck veins. The patient can cough and be short of breath. There can also be upper limb swelling. And then you'll see these chest collaterals. And then finally, sometimes they can get conjunctival like redness or suffusion. And this could indicate that they have a apical lung carcinoma. And then after inspecting, you'll palpate. So if I go back to this image of this nice image of the chest, so you'll be palpating for tracheal deviation. So at the suprasternal notch, feel for an equal space between the sternocleidomastoids. And then if there's an equal space, you know that there isn't a tracheal deviation. Remember that collapse pulls the trachea towards things, whereas effusions pushes the trachea. And then also, while you're feeling the trachea, feel for a tracheal tug. So basically, the tracheal tug is when you're feeling in that suprasternal notch, you'll feel a downward displacement of the thyroid cartilage during inspiration. And this is indication of a tracheal tug, which can show increased work of breathing or respiratory distress. So again, look, then feel, and then the second thing on feeling, so we felt the trachea, now chest expansions. So this indicates it quite well. You do this anterior and posteriorly. So you do the AP and lateral expansions. So anterior, posterior. So that's when you put your fingers just below the breast in the front of the anteriorly, and one finger posteriorly, and just see if the anterior posterior expansions seem symmetrical, and then also putting both your hands as indicated here on the chest wall to see if both sides of the chest are also expanding equally. And then you move on to percussion. So as indicated in this picture, you should have short nails, because you're only going to hurt yourself by percussing with long nails. It can be quite painful. So remember that when you're percussing, it's not a forceful movement, and it just takes practice. Remember to not percuss over the bones. So as we showed earlier, we avoid going where the ribs are. So you'll actually just feel the intercostal space and percuss over that area. And remember to percuss symmetrically. So if you percuss on this side, remember to percuss on the exact same side on the other side, so you can compare. And then, so percuss on the right, and then on the left, then the right and the left, because you're basically comparing. I've seen some people percuss down here and then down here. You're probably not going to do very well, because there's no point in that. You're trying to compare left and right. And remember to also percuss on the back, but also avoid percussing over the vertebral column. You will just hear dullness, bony dullness. So try and keep along here with your percussion on the back. Another important sign which you can feel or involved with percussion or palpation actually is something called tactile vocal fremitus. So this is when you place your hands over the back of the patient. So you can place both of them, you can place both of them at the same time. It will help you differentiate which one is felt better. So we ask the patient to say 99. And then in cases when there is areas of, so if, for example, a pneumothorax or a pleural effusion or tumor, the vibration you'd feel is reduced. But if there's consolidation, the vibration you'd feel is increased. So it's quite a good sign. So for example, in pneumonia, you'd feel increased vocal fremitus. And then moving on to auscultation. So generally breath sounds should be vesicular, and vesicular breath sounds normally have a short inspiratory phase and a quiet expiratory phase. You shouldn't really hear expiration. In terms of a wheeze, it's quite musical. It's like a little bit of a whistling because of airway narrowing, and it's usually expiratory. But so if there's a severe asthma or severe bronchoconstriction, it can be inspiratory and expiratory. It can be monophonic or polyphonic. So it means it can be quite musical and sound variable, or it can just sound like one constant sound. In terms of stridor, it's a high-pitched sound. It's generally also on inspiration. It's similar to a wheeze, but it's showing you that the obstruction is quite high up. Yeah, I suggest you just look at YouTube and listen to some of the videos. So stridor is indicating obstruction of the upper airway, so above the larynx. And then finally, crackles. So you get very coarse crackles, which sounds similar to when you're ripping off Velcro from something. So this happens when there's fluid in large air spaces like mucus. And then you also get fine crackles, which are just like a slight popping sound. So fluid in small air spaces, which could indicate pulmonary edema. Again, you could also listen for vocal resonance. So similar to tactile vocal fremitus, but this is listening now. With vocal resonance, you ask the patient to say 99 again. And then in areas of consolidation, the patient's voice is generally muffled. If both sides of the chest, so left and right, are normal, you will hear the 99 equally on both sides. But if there's consolidation, you will hear, normally in normal people, in normal patients, the voice should be muffled, And if you find it difficult to hear the 99, then it indicates that there's consolidation. So just to clarify, consolidation means that you'll hear the 99 very clearly, but if the lungs are normal on left and right, you'll actually hear that the 99, when the patient says it, sounds very muffled. Does everyone understand that? Okay, someone said, can I recap about the vocal resonance and tactile vocal fremitus? Okay, so tactile vocal fremitus is something you're going to feel on palpation. It's a vibration when you put both your hands on the patient's back. You ask the patient to say 99, and then you can move your hands down the back symmetrically, so comparing left and right. The vibration will be reduced if there's something like air or fluid or tumor. So a pneumothorax or pleural effusion or tumor, then the vibration you feel on one side will be reduced in comparison with the other side. If the vibration is increased on one side, this could indicate consolidation, and consolidation could indicate pneumonia. And then vocal resonance is when you actually use your stethoscope to listen. And normally, if a patient says 99, you could probably try this on someone at home tonight. Normally, if someone says 99 and you're listening with your stethoscope, the 99 will be muffled in normal, healthy lungs. But if there's consolidation, the 99 will be heard clearly. Hope that clarifies. Okay, so just to recap, so look around the bed and start to collect and put things together. So look for what's around the patient, then examine the patient always. Look, feel, and then listen. And then in terms of things you can suggest, so if you think the patient has an exacerbation of COPD, you could say you want to send off a sputum sample for MCNS. MCNS stands for microscopy, sensitivity, and culture. You might want to also put them on oxygen or suggest other observations you want to perform. And then you could also do peak flow and lung function tests, bloods, chest x-ray, and then a CT chest. But generally at your level, you could, if you're quite sure of the diagnosis, say CT chest. Yeah, it's really up to you. And then just extra steps. So if there's dullness in the bases, could this be consolidation? If it's one-sided, could it be collapse? Could it be pleural thickening or raised hemidiaphragm? And then in terms of investigations, you do some bloods, a chest x-ray, and then sputum. But remember that only if you're suspecting an infective cause will you send sputum off, because you will get asked why you're sending it off and what are you sending it off for. So in terms of sputum, you generally send for MCNS, like I said, microscopy to look at what actually, what organism is visible, or what bacterium is visible. Culture, so they actually try and grow it in the lab. And then sensitivity to see what antibiotic is able to kill the organism. And then if you want to suggest a pleural tap, you need to say why you're doing it and what you're looking for. And then just the extra step. So something important is if you have a pleural effusion, you need to know about the modified Lights criteria, which you can go over in your own time. And then other signs. So in cancer, you could see cachexia, which is just extreme emaciation or loss of or muscle wasting, clubbing, lymphadenopathy, bone lesions. They could also be in a female, evidence of a mastectomy. And then in COPD, you could see cachexia, pursed lip breathing, tripod positioning, because basically they're trying to increase their intrathoracic area, barrel chest, asterixis. And then in cor pulmonale, you could have a raised JVP and ankle edema. In infectious causes, so if there's TB, it could be apical infiltrate, so you could hear something in the apices of the lung. There could also be loculated empyemas, so empyemas when there's presence of pus. Trauma, so a hemothorax, and then connective tissue disease. There could be rheumatoid arthritis visible in the hands, and then congestive cardiac failure, raised JVP, ankle edema, cardiomegaly, but cardiomegaly you'd only really know on chest x-ray. And then cystic fibrosis, so this is actually a hint for the next question. So generally a young patient, short stature, there's clubbing of the fingernails, and a peg for feeding. So this is just to recap the causes of clubbing, which you can go over later. I like to group things in terms of systems. So also this way of grouping it on the side. Okay, so this is similar to the cardiovascular one. So just how I summarize my findings. So for example, if you had a patient with acute exacerbation of COPD, you'd say, I performed a respiratory examination on Mr. X, a 55-year-old with signs suggestive of acute exacerbation of COPD, which is evidenced by purulent sputum at the bedside in the sputum bottle, shortness of breath and accessory muscle use with a respiratory rate of 24, asterixis indicating CO2 retention, hyperinflation on percussion. So how you would tell that is if you're percussing where the liver should be, or you're percussing lower down, and that would indicate hyperinflation, and also if the liver is being pushed further down. And then with crackles on auscultation in the right lower zone. And then you mention your differential diagnoses, and then what type of bloods you would do. So you could mention an arterial blood gas on room air to assess oxygenation status, a chest x-ray to look for consolidation, blood, so the full blood count, look at the white cell count, see if there's any evidence of a bacterial infection, hemoglobin to look for polycythemia, which can be present in COPD, and then the U&E to look at the renal function, and then just mention your management. Okay, so does anyone have any idea what this picture and this is indicating? What diagnosis could this be?
There's a lot of people posting in the chat.
Okay, COPD, yeah, COPD. So cachexia, so the muscle wasting, the tripod positioning, the pursed lips a bit, and there's a bit of redness in his face. So it could indicate CO2 retention. And this is just showing barrel chest and the nicotine staining. So next one, can anyone tell me what this is indicating? Yeah, so cystic fibrosis. Why would you say cystic fibrosis?
The age of the child. And then the short stature, that means there is something chronic going on. There is finger clubbing with a peg tube for feeding, because there is nutritional impairment as well as a part of cystic fibrosis, the GA and RESP involved together.
Yep. Okay. Thanks for that. So this is just showing increased coughing and a cough productive of sputum. A young patient with short stature, finger clubbing, and a peg tube for feeding. So if you guys don't know what PEG stands for, it's a percutaneous endoscopic gastrostomy. And this is how it looks. And anyone have any idea what this could be showing? So the clue is the heart.
Cartogens.
Yeah, cartilaginous. So there's dextrocardia and they'll be coughing a lot. Yeah, good. Okay, so just a summary. So we go through Wiper QQ and then the double I, double PA, go through whichever method you like, just keep it systematic. So moving from the edge of the bed to the hands, arms, neck and face, then the chest and moving down to the legs. Don't forget to examine the lymph nodes. Remember to mention your differential diagnoses and then your investigations and finally your management. Now we have a little quiz if you guys want to try. I don't know if you want to post the answers in the chat. So 3 causes of clubbing and crackles, 5 causes of dullness on percussing the bases bilaterally, causes of bronchiectasis, and then 5 causes of clubbing. Yeah, so cartilaginous is a favorite of written examinations, and it's a primary ciliary, there's primary ciliary dysfunction. So they can also have infertility because if you think about cilia, they found in the lungs and then the sperm also need them. Has anyone put any answers in the chat?
We've got bronchiectasis and cystic fibrosis.
Okay. Cause of clubbing, COPD. COPD is generally not a cause of clubbing.
COPD is the one that people always say, and
But it's not. There has to be COPD with something else. Yes, lung cancer, interstitial lung disease, I'll take. Heart failure is not a cause of clubbing unless it's cyanotic heart failure, congenital cyanotic heart failure. Clubbing, lung cancer, yes. Cystic fibrosis, yes. Yep, good. 3 causes of clubbing and crackles. So someone just said, maybe just put the number you're putting down so that I know which questions have been answered. So just 1 and then your answer. While we're doing the quiz also, Natalie's just going to put the link to the feedback in the chat. So, or maybe at the end of the quiz, actually, it might get buried in all the stuff. Any causes of bronchiectasis? Good. So interstitial lung disease can cause clubbing and crackles. And then bilateral pneumonia wouldn't cause clubbing and crackles unless you're saying bilateral pneumonia for causes of dullness. But also remember that bilateral pneumonia is quite rare. So causes of dullness on percussing the bases, sorry, it can be bilateral or unilateral. So also mention unilateral ones. Asbestosis for question 3. I guess it could. Childhood infection, yeah. I've never heard of ulcerative colitis causing bronchiectasis. tumor and foreign body for cause of bronchiectasis? Yes. Okay, here are the answers. So 3 causes of clubbing and crackles. So pulmonary fibrosis, fibrosing alveolitis, asbestosis, bronchial carcinoma. I'm sure there are more, but these are the ones I could think of at the top of my head. 5 causes of dullness on percussing the bases. Pleural effusion, remember that this will be stony dull and generally one-sided. Pulmonary edema would be bilateral. And then consolidation, pleural thickening, or raised hemidiaphragm. Causes of bronchiectasis, so post-infectious. So if you had a serious infection as a child, could predispose you to developing bronchiectasis. Aspiration, so especially in alcoholics. Immunodeficiency, allergic bronchopulmonary aspergillosis, and then idiopathic. And then in terms of causes of clubbing, I like to group them according to systems. So cardiac causes, cyanotic heart disease, atrial myxoma, infective endocarditis. Respiratory would be lung cancer, chronic suppurative lung disease, such as cystic fibrosis, bronchiectasis, lung abscess, or empyema. And then pulmonary fibrosis. Then finally, gastrointestinal, inflammatory bowel disease. I guess, I think maybe the other person was referring to ulcerative colitis, was talking about clubbing, not talking about bronchiectasis. Maybe that's what it was. Cirrhosis or GI lymphoma. So this is just a quick CVS quiz and we're almost done. So can anyone name 3 clinical features of infective endocarditis?
Osseous node granulation, pallor, road spots.
Good. 3 causes of CCF. Yeah, so good splinter hemorrhages, Janeway lesions, pulmonary erythema, all good. 3 causes of congestive cardiac failure. Causes or precipitants? Anyone?
Hypertension, anemia, heart disease.
Good. So top number 1 cause, hypertension. Number 2, I'd say atherosclerosis or previous MIs. And then, yeah, valvular lesions can result in heart failure, anemia, yes, thyroid problems. So what's the normal pulse rate? Question number 3. So 60 to 100, good. And then just when describing murmurs, what should you always include in the OSCE?
Grade of the murmur.
Yeah, the grading.
Whether it is systolic.
Diastolic, good.
What are the features that increases the murmur, like position, postural variation, or respiratory variation?
Good.
And the site of the murmur.
Good.
Whether any radiation or conduction.
Yeah, and radiation. Good. So just to recap, that was location, accentuated by inspiration or expiration, or position, so sitting up or lying back. And then radiation and the grade of the murmur. So these are some of the answers. So in the eyes, you could see rot spots. In a clinical exam, I don't think you'd be expected to do fundoscopy, so you might not see the rot spots. Hands, Osler's nodes, Janeway lesions. Nails, you'd see splinter hemorrhages. Arms, you could see needle track marks. They could have a fever or a new murmur. And then 3 causes of CCF. Hypertension is number 1. Number 2 is ischemic heart disease. You could also get infective or immune causes like viral causes, HIV, or sepsis, autoimmune causes like lupus or rheumatoid arthritis. In terms of genetic causes, you could have HOCM or dilated cardiomyopathy, volume overload in renal failure or nephrotic syndrome, liver failure, or infiltrative disease like sarcoid or amyloid. And then also hemochromatosis, and then structural heart lesions, so valvular heart disease or septal defects. So congenital septal defects. And then normal pulse rate is 60 to 100, and then we've all described the murmurs. So just a final point, you just need to keep practicing, practice on anyone and everyone you can practice on with their permission, of